Good morning. I'm going to come out here to be able to interact a little better with y'all, and maybe either Tom or I'll use this as my pointer. Good. So I'm going to be talking to you about Health Sciences Online, which is, this is our purpose, is democratizing health sciences knowledge. And what we are is an aggregator of many of the programs that you've heard about this afternoon for the last couple of days. And this is me. I've been working on this initiative for the last decade. So this is the problem that we're working on fixing in a very wholesale way. We've heard about some remarkable individual collaborations and collaborations within countries and across a couple countries. Our aspiration is to help solve the global health manpower shortage with using ICT, which is what we've been hearing about and what WHO says that you need to do to be able to fix the health workforce shortages, that we can't just do it with more bricks and mortar schools. So this is what we've done already. We are the first and only website to occupy 4 spaces. We're authoritative, comprehensive, free, and ad-free. We have over 50,000, resources, all sorts of learning objects, references, guidelines, textbooks, videos across the health sciences. And we're adding thousands more every month. These materials come from extraordinary institutions. Some of them are officially open courseware, some are on government sites, some are from specialty societies, but they all have to be from institutions that either give degrees or are certified to give continuing education. And they're available in 52 languages through the magic of Google Translate, which I'll show you in a minute. So this is the home page, and one enters a search query into the bar. And sorry, you probably can't see that in the back, but this is a search on diabetes, and you can see there are materials from WHO and from NIH and University of Utah, BC Ministry. Extraordinary resources from extraordinary institutions that I think any of us would have been pleased to have learned from. And you can also refine these resource types. So if you're interested in diabetes and you want to look at images of below-the-knee amputations, you could look at the Atlas, for example, for that. These are the languages that it's available in, and we have physicians and other health providers whose first language is not English, who looked at the translations, and they're quite good. They're not perfect, but as you'll see in a moment, there's some backups for it as well. So this is what the search looks like for diabetes in French, but one of the nice backups is that you hover your mouse over anything that's been translated into any of these 52 languages, and it automatically shows you the original English text as well. So it looks like in Chinese. Now I'm just kind of showing off, and in Japanese. But it's not just the searches that are in these 52 languages, it's the resources themselves get translated on the fly into these 52 languages as well. So that's what we've done so far with phase 1. And I'm going through this fairly quickly because I hope we'll have some additional time for dialogue, and I want to be able to open that up a bit. And we're committed to continuing this with phase 1. To continuing this extraordinary health sciences library. These were our founding collaborators and funders for our first phase. Most of the funding, though, came from individuals who spent enormous amounts of time volunteering to make these resources freely available. But we also have some wonderful organizations, obviously, that have partnered with us. We have, as of June, we were at 6,000 hits a day. We're now at about 10,000. This is my favorite slide to gloat about. Jeff Copeland, of course, is someone who's familiar to many of you. He actually, this quote was originally, he called me a visionary undertaker. And I asked him if perhaps we might be able to morph that a little bit into something that I was a little more comfortable with. But we have some nice buy-in from a lot of good organizations. I think this is probably my favorite quote, this one at the end. So for phase 2, we're continuing what we've done with phase 1. We're maintaining this library. It's available to anyone for free, anyplace, www.hso.info. But we're taking a second step as well. which is that we really want to address this need for additional healthcare workers. So we're aggregating our aggregation, and let me show you what that looks like. We're using a community-based distance health education model so that people are able to be trained in country, so we are able to reduce brain drain. Everyone who takes any of the courses that are clinically oriented has a mentor, an attending essentially, with whom they practice their clinical skills and from whom they get questions answered, because that's the kind of thing that can only be done human to human. And then we're giving them their didactic training, their knowledge transfer, using extraordinary computer-assisted instruction. So let me show you an example. This is the machine that we've built. It's not really a machine, it's powered by humans, but it's the model that we've used that allows us to create remarkable courses extremely inexpensively. And I'd be delighted. My whole purpose for being here is my last slide, which has my email on it. So I hope that this is a model that has some appeal to some of you and where you'd be interested in participating. So this is the training that we're doing in physical activity and health. Our partners are the CDC and the American College of Sports Medicine, as well as a small grant that we got from a foundation in Colombia. So this is lots of South-South and South-North and every direction you'd like to talk about. So these are what we do is we take existing competencies. So for example, the American College of Sports Medicine says you need to have these 4 competencies about physical activity and health to become a certified personal trainer. And the Canadian Society for Exercise Physiology says you need to have these competencies to become a certified exercise physiologist. We take these competencies here and we move them into a spreadsheet here. And then we find existing, outstanding, open materials that are available and we link to them. And we try to have several resources for any one competency. We like to have different media. We also we had talked about this issue of what happens if somebody pulls something, since we're just linking to resources. If somebody pulls something, we need to have backups. So these are we match competencies with existing outstanding resources. And then we take those, we organize them into modules like Introduction to Physical Therapy. And then we migrate them into Moodle. This is a part, obviously, that we pay for, but it's not that expensive to migrate courses into Moodle. For a typical course, it costs about $400 for me to pay a work-study student subsidized from UBC to migrate resources into Moodle. So there's an introduction to the resource, and then you walk your way through the resources. And you can see these are, to me, just magnificent resources. This is my favorite one to pause on. This is similar to many of the kinds of outstanding resources that have been talked about at this meeting. But I'll tell you, I went to Yale and I went to Stanford and I did my internship at the Cleveland Clinic, and nobody ever told me 7 steps how to perform a skin exam. But this resource does. And even from the back, you can probably tell, yep, that one is actually what a targetoid lesion looks like, and that's what an arcuate lesion looks like, and a linear lesion. I mean, I don't need to sell y'all on the beauty of using computer-assisted instruction, but we've had a lot of talks for the last hour and a half and for the last couple of days about why are we redoing things that have already been done. So what we have done here is made it so that you don't need to redo things, you just need to come to our site and find them. So all of the trainings have 4 methods of assessment available. We have objective assessment, which of course is what most people care most about. We have mentored assessment. So if you're doing the dermatology training, for example, and you're spending a month doing the dermatology training, you might spend an afternoon a week during that month with a doc or a nurse or a clinic and say, please send me your dermatology patients this afternoon, and then I'll come and talk to an attending about them. So you get to practice some of the skills. And then the mentor assesses you, pass-fail at the end of it. And then there are also peer-to-peer trainings. So again, if you're doing dermatology, you might, Mary talked about taking images of things. So you might take an image of a rash, and you would be randomly assigned to another trainee doing the dermatology training someplace else. They would be expected to give a diagnosis and a proposed treatment, and you correspond with them about that one, and then you perform the same function for another peer who you get randomly assigned to, and you look at their images, and you come up with a diagnosis and treatment for it. So, and the fourth method besides mentored assessment, peer-to-peer assessment, objective assessment is self-assessment. So we have rich ways of evaluating people, but ways that are also, from our perspective, fairly automated and permit tremendous efficiency. So this is my penultimate slide. I'm going to pause on this for a moment because these are educational initiatives, trainings that we have that are already underway. So this is not just a fantasy that this is achievable, but all of these will be ready within the next few months for beta testing. We're planning our hard launch for January of 2012, but over this next year, all of these trainings are going to be tested in the field. And you can see that they're quite wide-ranging in their topics, from, I guess, public health to surgery. I hadn't realized that's kind of how it stacks up. But and these, for example, these 5 public health trainings, these are the equivalent of the core of an MPH, and they can be supplemented then with modules like the physical activity and health one that I showed you, or several other that are relevant to public health that you could essentially put together a full MPH. We're working on all of these with separate partners. The work is typically done by a specialist in an area who is willing to take a month or so, often spread out over several months, to pull together these materials. So they find the competencies, and then they find resources to pair with the competencies and create short introductions to each of the modules. So it's not particularly labor intensive, and it's, of course, the incremental costs for administering this to an additional student are essentially nothing. So those are the areas in which we're training. Some of these are done in extremely close partnership. Some we just are fortunate enough to have organizations also that are willing to co-brand with us. For example, NATO's Science for Peace program gave us a grant to do some work in Armenia and Georgia. They're not as involved in creating the content, of course. I don't think anyone really wants to learn about dermatology from NATO, but they were kind enough to provide some funding. So I think that that's probably all of what I wanted to show you all for now. Again, this is where I am now at UBC. I still help run the preventive medicine residency program at Emory. And that's, one of the ways that these kinds of trainings have developed. We have preventive medicine residents with expertise in infectious disease, for example, who are working with us and with WHO's infectious disease group to create a hospital and clinic-based infectious disease control program. So that's how we tend to accumulate people, is by talks like this and by working with a wide variety of partners. So thank you, and I'll look forward to talking with you more about it.